Hi guys, welcome everyone back to the Master ECG series. So we'll continue from where we have left. We have discussed about the P waves, PR segment, PR interval, QRS complexes, and ST segment. So today we will be talking about the P wave abnormalities. Now, of course, I do agree that when it comes to ECG, the PR interval, P waves, QRS interval or QRS complexes, and ST segment are extremely important. But P wave abnormalities are useful in diagnosing certain acute conditions which can be life-saving to the patient. So that's why we should be well versed with the T-wave abnormalities. So we'll start today about the T-wave abnormalities, and our template of learning is going to be standard. First, we will understand how a normal T-wave is supposed to look like. Only when we know what is normal, we will be able to identify abnormals, right? First, let us understand the normal T-wave. But before going to the T-wave itself, I want you to go through this one question and then tell me what do you think. I will zoom in and show the ECG, but before that, the story. So in this case, we have a 40-year-old male who collapsed in the gym after intense workout. He was working out for 3 hours. Okay. Now let us keep the rest of the question aside. What differential diagnosis you can think of when someone collapses in the gym or while doing some physical activities or exercise? Especially young or middle-aged individuals collapsing in the gym while doing some activity, gym or other exercises or other exercise activities like running marathon. What differential diagnosis you can think of? I know most of us first answer that comes to our mind is going to be hypertrophic cardiomyopathy, HCM. Other than that, we would think of myocardial infarction, right? Some rare complications of intense workout like severe dehydration, electrolyte abnormalities. These are the things that come to our mind, right? Okay, now here ECG is done on arrival to the emergency room and the ECG findings are evident here. Okay, and what examiner is asking, is this patient going through MI? Is this patient going through hyperkalemia? Is this patient going through hyponatremia, or is he going through hypokalemia? And here is the ECG, right? I have zoomed it for you. Look at the ECG. We all know that we're talking about T waves. So of course you're going to concentrate on the T waves. And as you notice, there are tall T waves. So what should be the answer? 40-year-old who was doing some intense workout in the gym for a very prolonged period, that is 3 hours, and then he suddenly collapsed. And when he was brought to the emergency room, this is what ECG showed, right? It is showing tall T waves. Now, what do you think should be the diagnosis? Okay, so Umesh says hyperkalemia is my answer. Now, let me pose another important question. What is the earliest ECG finding in a patient with STEMI? If someone is going through ST elevation MI, what is the earliest ECG finding in STEMI? Remember, the earliest ECG finding in STEMI is also going to be tall T waves. Tall T waves. In hyperkalemia, we get tall T waves. And as earliest finding of the ST elevation MI, we get tall T waves. First, tall T waves come, then ST segment gets elevated. So now, because I am getting tall T waves here, both are possibilities, right? Intense workout might have precipitated an MI, or patient would have gone through what we call as rhabdomyolysis because of intense workout. And when muscle breakdown, the potassium which is held in intracellular compartment of the muscle may be released into the blood, and then also I can have hyperkalemia. So both are possibilities. How to deal with this, right? We will come back to this question after we have studied about the abnormal T waves. After that, this becomes little easier. Okay. So let's begin by first understanding the normal T waves. We all know that T wave is a wave of ventricular repolarization, and a normal T wave is supposed to be upright in all leads except two. One of them is AVR and the other one is V1. So in these two cases, the T wave is inverted. In the lead AVR and in lead V1, the T wave is inverted. In all other leads, it is supposed to be upright. Okay. Now, if it is a wave, it should have a duration and it should have height in the form of voltage or amplitude. So what is the normal T wave amplitude? The normal T wave amplitude is not constant for all leads. I'm not going to say that take any lead, the T wave should be less than this. The normal T wave should be less than 5 millimeters. In terms of voltage, that is equivalent to less than 0.5 millivolts in the limb leads. And in case of the chest leads, precordial leads, V1, V2, V3, V4, V5, V6, it should be less than 10 millimeter or 10 small squares. In terms of voltage, it is 1 millivolt. It should be less than 1 millivolt. So when it exceeds this, when it is taller than this, we would say there is tall T wave. So if I look at the limb leads, what are my limb leads? 1, lead 2, lead 3, right? AVR, AVL and AVF. These are my limb leads. So in the limb leads, if the T waves are taller than 5 small boxes or 0.5 millivolts, then we will call it as tall T wave. Okay. Otherwise, it is normal. And in the precordial leads, that is my V1 through V6, if it is more than 10 small boxes or 1 millivolt, we will call it as tall T waves. Clear? Otherwise, amplitude wise, in the limb leads less than 5 small boxes, and in the precordial leads less than 10 small boxes. In terms of duration, I cannot define the normal duration of T waves, because with variation in the heart rate, with variation in the QT interval, the T wave duration also increases or decreases. So it is related to QT interval. So that is why we never make a diagnosis of some pathology based on the T wave duration. We will definitely discuss about the QT interval in another session, where we will understand the corrected QT interval and abnormalities of QT interval. So if you are making a diagnosis, it is going to be based on QT interval prolongation or shortening and not based on the T wave duration. Okay. But T wave amplitude is important. So first thing we learned is that in the limb leads, 5 small boxes, and in the chest leads, 10 small boxes. Okay. Then the second important point I need to emphasize is that the normal T wave, when I look at a normal T wave, and if I draw a midline, separating the T wave into 2 equal halves, what we notice is it has an ascent and a descent. Now, this normal T wave is not symmetrical. The descent is more steep. Means what is steep? It's diving down at much smaller angle, right? When you see it, this is a midline, and then on this side the angle is larger, on this side the angle is lesser. There is a steep dive. So the normal T wave is asymmetrical. Normal T wave is asymmetrical because it has a steep downslope or the descent. Thus, normal T wave is asymmetrical. It is not symmetrical. That is a very, very important point. So let me summarize again what we have discussed. T wave is upright in all the leads except AVR and V1. In the limb leads, it is supposed to be, in terms of height, it is supposed to be less than 5 small boxes. And in the chest lead, it is supposed to be less than 10 small boxes. And when I look deeply, the T wave is supposed to be asymmetric, not symmetrical. It should have more steeper downslope in comparison to the ascent. This is our normal T wave. Now, what can go wrong with T wave? The T wave can be either tall or it can become inverted. It can become taller or it can become inverted. Normally, it is upright in most leads. It can become negative in most leads. Okay. So first we will address in what conditions tall T wave can be seen. So tall T wave can be seen as a normal variant. Many normal individuals can have tall T waves. The normal variant is usually restricted to V2, V3, V4. Not in all leads, but V2, V3, V4. Then it can be because of hyperkalemia, where we call it as peaked T wave. We will call it as peaked T wave, or it is also called as tall tented T waves, which is seen in hyperkalemia. Which is something that we all are familiar with. And then we have one more condition, which is called as hyperacute T waves. Hyperacute T waves of myocardial ischemia. So when someone is going through myocardial ischemia, we can get hyperacute T waves. I have already told you this hyperacute T waves or tall T waves are the earliest sign of STEMI on the ECG. So these are the 3 conditions where I can get tall T waves. Now the question is, how will I differentiate between these 3? Because in all the 3 we are getting tall T waves, whether it is because of hyperkalemia, myocardial ischemia, or is it normal variant. So first thing is the normal variant. If I'm seeing tall T waves, I'm seeing only in V2, V3, V4, and they are going to be asymmetrical. Because remember, normal T wave is asymmetrical. On the other hand, both these conditions, there will be symmetrical T waves. So T waves which are tall but asymmetrical, maybe normal variant, but T wave which is tall and it can be equally halved into right side and left side, it is symmetrical, then it is most likely pathological. Most likely pathological. I hope the point is clear. Okay, so now let us go back to this ECG and see what do we get here. Is this T wave symmetrical or asymmetrical? Okay, so as I see here, this is a PR segment, you notice. R wave goes up, then comes down. This is my Q wave, an angle being formed here, right? I can consider this as the J point. From there, ST segment begins, and here I can see another angle being formed. So I will count this as the beginning of the TP segment. So this is my T wave, right? So I find my T wave here. And when I look at it, it seems to be symmetrical, equally halved between both the two sides. So this is symmetrical. So I will count this as pathological, not a normal variant. Second thing I told you that normal tall T waves are usually seen in V2, V3 and V4, not in most leads. So here beyond V2, V3, V4, I'm seeing tall T waves in other leads also. So I'm not considering normal variant here. And looking at the symmetry, I'm considering pathological. So what are the options I'm left with? I'm left with either hyperkalemia as a possibility, or I'm left with myocardial ischemia as a possibility. So let us learn how to differentiate between hyperkalemia and myocardial ischemia based on the tall T waves. Okay. So first, the tall T waves of hyperkalemia, we will call it as peaked T waves, right? They are also called as, also known as tall tented T waves. Tented T waves. Why are they called as tented T waves or peaked T waves? Because here the T wave has a very sharp peak. It has a pointed peak. And when I compare that to the hyperacute T waves, like you see here, this is also tall T wave, but here the T wave is not very pointed. It has a blunted tip. It has a blunted peak. On the other hand, when I look at this ECG, it has a pointed tip, right? Pointed peak or the tip. That's why it is called as peaked T waves or tall tented T waves. You know, the tents that we put when we go for camping or trekking, they have this peak, sharp tip, right? That's why it's called as peaked T waves. Now, what are the characteristic features of this? First thing is the base, right? It has a narrow base. The first thing we will notice is this peaked T wave has a narrow base. It is not very wide at the base. Second thing we notice is this has pointed peak. It has a pointed peak. The third thing we notice is this has symmetry, right? This is symmetrical. Remember, normal T waves are asymmetrical. The ascent is not very steep, but the descent is more steeper. So it makes the T wave become asymmetrical. So here I have a T wave which is symmetrical. Of course, tall, as we have defined, more than 5 small boxes in the limb leads or more than 10 small boxes in the chest leads. And then being symmetrical, being tall, it has a pointed peak and has a narrow base. So base is not very wide and it is having a pointed peak. Then we call it as tall tented T waves or peaked T waves, right? Typical of seen in hyperkalemia. Seen in hyperkalemia. As you see in this illustration, this is the T wave which is perfectly symmetrical between the two sides. The base is not very wide and the peak is little pointed. Okay, that's what exactly I get in this ECG, right? The base is not very wide. It is kind of pointed peak and it is symmetrical, right? Equally distributed between the two halves. This is very classical ECG of hyperkalemia. In this ECG, of course, there are other changes that we get in hyperkalemia, which we will be discussing tomorrow. Tomorrow, we are going to talk about the ECG changes in electrolyte abnormalities. Today, we are focusing on identifying abnormal T waves. The second abnormal T wave is called as hyperacute T waves, which is seen in patients with myocardial ischemia. Seen in myocardial ischemia. The point to remember about this is that these hyperacute T waves are the earliest ECG finding. This is an MCQ that has been asked already. Earliest ECG finding in patients with ST elevation MI. So does this have a localizing value? Of course, yes. If I see these hyperacute T waves in lead 2-3 AVF, that means I am suspecting inferior wall ST elevation MI. The same patient, if I repeat an ECG after 20 minutes or 30 minutes, ST segment elevation may be evident by then. So earliest change is hyperacute or tall T waves. So first I see tall T waves. After some time, the ST segment gets elevated. Of course, most of the patients, by the time they come to hospital, ST segment elevation may be evident. But if they come quite early, I may be able to see them with only hyperacute T waves. And this is a STEMI equivalent that we should be aware about. Now, how is this hyperacute T wave different from the peaked T wave that we were getting in hyperkalemia? Well, now when I look at this ECG, the first thing that we will notice is that the base is wide. Of course, it is symmetrical. Symmetrical is pathological. Asymmetric can be normal. This is symmetrical. This is tall. And when I look at the peak, right, it has a blunted peak. It is not sharp or pointed peak. It has blunted peak. Second, it has wide base. Wide base comparison to the peak T waves of hyperkalemia. And then this is also symmetrical. Symmetrical. So these 3 points will help me to differentiate between normal tall T waves versus hyperkalemic tall T waves versus hyperacute tall T waves of myocardial ischemia, right? So when you see this ECG, you can understand, right? Compare this ECG, take a close look, compare this with the ECG that we had seen here. So here the base is not very wide, right? And the peak was pointed. And in this ECG, the peak is blunted, right? It is not pointed. It is little blunt, and then the base is wide. This point will help me to identify hyperacute T waves. Okay. Like you see in this ECG, this patient is presented with chest pain, and when we look at it, it has broad base, tall T waves with broad base and blunted peak. So this is very typical of myocardial ischemia. Okay, so with this background understanding, we will go back to that question that we had taken in the very beginning and see now if we can answer. A 40-year-old male collapsed in the gym after intense workout of 3 hours. ECG done on arrival in the emergency room, shown as given below. And what is the likely cause for this patient's condition? Myocardial infarction, hyperkalemia, hyponatremia, hypokalemia. Okay. So let's concentrate on the T waves. So what do we notice here? T waves are of course tall. How did we define tall T waves? If I'm looking at the chest leads, that is V1 through V6, it should be more than 10 small boxes, right? So here it is definitely more than 10 small boxes. So that means there is tall T waves. 10 small boxes is 2 large boxes. It is more than that. So T waves are tall. So tall T waves agreed. Second thing is whether it is symmetrical or asymmetrical, because I need to rule out normal variant. Of course, these are symmetrical, equally distributed between both the sides. It doesn't seem to be very steep descent, right? All these are equally distributed. So that means it is symmetrical. So that makes it mostly pathological. Another point that goes against saying that this is not normal variant is generally normal tall T waves are encountered in V2, V3, V4, V2, V3, V4, not in all other leads or extensively across different leads. So keeping those points in mind, I will count this as pathological and not normal. And when it comes to pathological tall T waves, I have 2 things to differentiate: hyperkalemia versus early change of STEMI. Now when I see here, the peak is pointed, right? The base is not very wide. The base is not very wide and the peak is pointed. So taking those 2 points into account, I will consider hyperkalemia in this ECG, right? We will go ahead with hyperkalemia. On the other hand, if I had got wide base and a blunted peak, I would have considered it as early ECG finding of STEMI. In the scenario, both are possible, right? When someone is intensely working out, that might precipitate an MI, as well as rhabdomyolysis may cause hyperkalemia. But from the ECG point of view, we can stick to our diagnosis of hyperkalemia. So what we have learned so far, T wave can be tall in normal variant, hyperkalemia, and as an early ECG finding of STEMI. Normal variant tall T waves are only seen in V2 through V4 and they are asymmetrical. So if it is symmetrical and it is seen beyond V2 to V4, then it is always pathological. The pathological, all I have to see is whether the base is wide and peak is blunted, or whether the base is narrow and peak is pointed. If there is narrow base and pointed peak, hyperkalemia. If the base is wide and blunted peak, ischemia, right? That's how we differentiate between the tall T waves. Now after the tall T waves, let's talk about the inverted T waves. T waves can be inverted in various conditions. Okay. So can you name some conditions where T waves are inverted? After that, I'll go through some images so that we will be able to understand. Shankar Gowda, I will address it. I will address your query. Can you name some causes for inverted T waves? What I do is I divide the causes for inverted T waves into ischemic and non-ischemic causes. Ischemic and non-ischemic causes. Because T wave inversion can be a sign of myocardial ischemia, and it can also be seen in various other conditions where there is no ischemia. Okay. Ischemia plus non-ischemic. Non-ischemic, we can have it in conditions like left ventricular hypertrophy, right ventricular hypertrophy. We can have it in right bundle branch block. We can have it in left bundle branch block. We can have it in patients with pulmonary embolism, and we can also have it in patients with raised intracranial tension, increased intracranial tension. These are few causes for T wave inversion which are not ischemic. This is not because of the myocardial ischemia, right? So we'll now talk about the inverted T waves and how to identify those inverted T waves. So far, we have already defined what is normal T wave, right? Normal T wave is upright in all leads except AVR and V1. So if I find a negative T wave in any of these leads except AVR and V1, I will consider it as T wave inversion. So when I see T wave inversion, it can be because of various causes. First is the ischemic causes. Ischemic causes. It can be because of myocardial ischemia or infarction. Now, how do I identify whether the patient is going through the ischemia right now or it is because of old infarction? Remember, when I have ST elevation MI, first thing that happened was T wave become tall, hyperacute T waves that we just discussed. After that, ST segment gets elevated. After that, everything starts settling down. The ST segment comes to baseline and then T wave gets inverted. So the Q waves and inverted T waves are the telltale sign that patient had gone through an episode of MI. So they will persist. So if that is the case, when someone comes to me with some symptoms and I get an ECG done and I see that the T wave is negative or inverted, it can mean either he is going through ischemia right now or it may be old ischemia, right? Old MI that he has gone through. How do I differentiate between the two? Remember, if the T wave inversion is varying, fluctuating, it is becoming more or it is becoming less deeper, then it is suggestive of acute ischemia. Acute ischemia. For example, I got one ECG done where the T wave inversion was of two small boxes, and then when I get the next ECG, it has increased or it has decreased. We'll call it as dynamic T wave inversions, variation in the depth of T inversion. It is suggestive of acute ischemia. But if it is fixed, right, I get it done once and I get the ECG done again, it looks the same, then it is fixed, right? Fixed is suggestive of old infarction. It can be suggestive of old infarction. And when I'm talking about old infarction, it is often associated with, it will be associated with pathological Q waves. Pathological Q waves. So in whichever leads I'm seeing T inversions, I will also be seeing the Q waves identified. That is pathological. Now we can also see T inversions in bundle branch blocks apart from ischemic. Ischemia, always the most important cause we should think of when we see T wave inversion, especially in the context of someone having chest pain. But if someone comes to me without chest pain and I get a random ECG done and it shows T inversion, there are various other non-ischemic causes possible. So one of them is bundle branch blocks. So we can see T wave inversions in both the right bundle branch block as well as left bundle branch block. I don't think I have covered the bundle branch blocks. We will discuss that in another session in detail. But for now, what I want you to concentrate on is look at the lead V1, lead V2, lead V3, and you notice that the T waves are inverted. As I've already told you, AVR and V1, they can be inverted, but all other leads, they're supposed to be upright, right? So I'm expecting to see a T wave like this in V2, V3, but I'm seeing inverted T wave. So this is actually ECG of a patient with the right bundle branch block. So this patient with RBBB is showing inverted T waves. So it can be seen. Of course, we will diagnose the RBBB based on other parameters, not just based on the T wave inversions. We're just getting used to it. Okay. So similarly, you can see an ECG of left bundle branch block, and there also you will be able to see some T wave inversions. Then we can get T wave inversions when we have ventricular hypertrophy, whether I have right ventricular hypertrophy or left ventricular hypertrophy. In the previous video module, we have discussed how to identify RVH and LVH. The point to note here is that when RVH or LVH are accompanied by T wave inversions, we call it as strain pattern, right? It is called as strain pattern. T inversions associated with RVH or LVH are called as strain pattern. So whenever some doctor says there is LVH with strain, right, this is something that you routinely hear. There is right ventricular hypertrophy with strain, left ventricular hypertrophy with strain. He is pointing towards the presence of T wave inversions. So now look at this ECG. This is a patient with the right ventricular hypertrophy. I diagnose that based on the prominent R wave in V1 with the R by S ratio greater than 1 in V1. That is a criteria that we have already learned. So when I see this closely, I notice that in lead V1, there is T inversion. In lead V2, there is T wave inversion. In lead V3, there is T wave inversion. In lead V4, there is T wave inversion. Lead V5, it is upright. So I am seeing T wave inversion in multiple leads. It is because of the right ventricular hypertrophy with strain pattern. Similarly, if I show you a ECG of left ventricular hypertrophy, as you see in this image, this patient has left ventricular hypertrophy, which we can comfortably diagnose based on what we call as Sokolov-Lyon criteria, which we have discussed in the previous video. If I apply that, this turns out to be a case of left ventricular hypertrophy. And when I look closely, I notice that there is T wave inversion in V5 and V6. This is again strain pattern, left ventricular hypertrophy with strain pattern. So that is the second cause. So first cause, non-ischemic cause, bundle branch blocks. Second non-ischemic cause, ventricular hypertrophy. Then third non-ischemic cause, pulmonary embolism. Pulmonary embolism often causes T wave inversions in the right-sided leads, which is V1, V2, V3. So as you see here in this ECG, you can see that there is T wave inversion in V1, V2, and V3. Apart from that, one classical finding which has been asked routinely during bedside discussions, Viva, OSCE, and MCQs, a very specific ECG finding of pulmonary embolism, but not very common, very, very rare, but very specific. That is S1, Q3, T3 pattern. So when I say S1, Q3, T3, what am I referring to? I am referring to visibility of S in lead V1, which is not normal. Normally, S is not prominently visible in lead V1. Plus in lead 3, Q becomes prominently visible, which is again not the normal scenario. And then T becomes inverted, right? We are talking about inverted T waves. Let us see whether I have it in this ECG. So when I look at lead 1, I can see that the S has become prominent, easily identifiable, which is not the normal case, right? I can see PR segment, R wave, S comes down. So S is prominent, easily identifiable in lead 1, that is S1. And then when I look at lead 3, Q wave is prominent, right? Q wave is prominent. So there is Q3 and then the T wave is inverted. So that is T3. So apart from the common finding of T inversion in V2, V3 and V2, V3 and V1, I'm also getting S1, Q3, T3 pattern, which is highly specific for pulmonary embolism. So that means this ECG is most likely a patient with pulmonary embolism. If you tell me that this patient had taken a flight, after that he came back with a swollen leg, and after that he started becoming short of breath, the context ECG fits perfectly, and I will make a diagnosis of pulmonary embolism. Okay. Now, what other conditions I can have inverted T waves? There is something called as cerebral T waves. Now, what do I mean by cerebral T waves? That means heart and the brain are connected. So when there is increase in the intracranial tension, various physiological changes happen. Increasing intracranial tension activates the vagus nerve, we get into bradycardia, but at the same time the blood pressure increases, so we can have hypertension and bradycardia, and we can also see the telltale signs of increased intracranial tension on the ECG. Again, with respect to T waves, what happens? T wave become inverted, but they are too deeply inverted and their shape is bizarre. So normally when we were talking about T waves, we said normal is asymmetrical, symmetry is pathological, and again when it is asymmetrical, the normal asymmetrical, the downslope is more steep. That's how we define normal T waves. Now here the shape becomes a bit bizarre, not like the usual T inversion that we were seeing in earlier ECGs. So this is a patient with intracranial bleed and raised intracranial tension. And when I see here, there is widespread, not restricted to some leads, widespread T inversions, V1, V2, lead 1, 2, 3, right? Then I can see that in AVF, I can see that in V2, V3, V4, V5, V6. So multiple leads, widespread T inversions, which are way deeper, right? Look at this from the baseline, they're too deep, and compare that to the T inversion that we had seen in other conditions, right? Deeper, bizarre shaped T inversions, widespread in multiple leads. See, in pulmonary embolism, when I showed only V1, V2, V3 and lead 3 showing T inversions. But when we have such widespread T inversions, which are deep and bizarre shaped, we call them as cerebral T waves, which suggests that patient has got raised intracranial tension, seen in patients with raised intracranial tension. The cause for raised intracranial tension could be anything: intracranial tumor, bleeding, right? Or meningitis, meningoencephalitis, brain abscess. It could be anything. But whenever there is a rise in the intracranial tension, we can see this. I have personally seen a lot of patients with subarachnoid hemorrhage presenting with this ECG finding. Many times my staff come to me with the ECG saying that, sir, this patient also has some cardiac problem. I think shall I refer to cardiologist? But from the history, it is evident that he had a subarachnoid hemorrhage. It is evident on the CT or MRI. So then I probably don't need to investigate for the cardiac issues. These are cerebral T waves. So these are all the abnormalities of T waves that I wanted to cover today. I'll give you a summary in next 4 or 5 minutes, and then we will wind up for today. There will be few questions which you can address from the notes. So let us first understand what is the normal T wave. Normal T wave is the wave of deep repolarization of the ventricle. It is upright in all leads except AVR and V1, where it can be inverted. The amplitude, normally it should be less than 5 small squares in limb leads and 10 small squares in the precordial leads. Anything more than that can be counted as tall. In terms of its duration, there is no predefined normal duration because it varies according to the QT interval. Okay. And the normal T wave is asymmetrical. It is not symmetrical. It has less steep upslope but more steep downslope, making it an asymmetrically shaped structure. Okay. Now the T wave can be tall or inverted. Tall can be normal variant, or it can be because of hyperkalemia, or it can be because of the MI. The normal variant is usually seen affecting only V2, V3 and V4 and not all the leads. And even when normal variant has caused the tall T wave, it will still remain asymmetrical. It will not be symmetrical. So if I get a tall T wave defined by the size in the limb and precordial leads as we have learned, but it is symmetrical, I will count it as pathological. Now to differentiate between hyperkalemia versus myocardial ischemia, all I have to do is whether it is broad based or narrow based, whether the peak is pointed or blunted. Narrow based pointed peak is hyperkalemia. Wide based blunt peak is hyperacute T waves of myocardial ischemia. Similarly, T wave can be inverted. It can be inverted because of ischemia or because of non-ischemic causes. Ischemia, of course, analyzed from the context, patient presenting with angina or chest pain and then ECG showing T inversions, I will count it as ischemic. There, if the T wave inversion is changing with time, like second ECG, third ECG, it is either increasing or decreasing, we will call it as dynamic T wave inversion. It is suggestive of ongoing ischemia. There is an acute MI going on. On the other hand, if the T wave inversions are fixed, like I get a ECG done at presentation later, and it still remains same, it is mostly suggestive of an old infarction and not the current ischemia. Okay. Then the non-ischemic causes, we can talk about left ventricular hypertrophy and right ventricular hypertrophy, where the T wave inversion is because of strain pattern. Bundle branch blocks, few leads, there may be T wave inversions. And then pulmonary embolism. Pulmonary embolism will show T wave inversion in lead V1, V2, V3. Along with that, it may show what is called as S1, Q3, T3 pattern, which is highly specific for the pulmonary embolism. S1, Q3, T3. Prominent S in lead 1, identifiable pathological Q wave in lead 3, and then inverted T waves in lead 3. Okay. And then it can also get T wave inversion when there is raised intracranial tension. We call it as cerebral T waves. Regardless of the cause for raised intracranial tension, we can have widespread, deep, bizarre shaped T wave inversions. Then we will call it as cerebral T waves. So that's it for today on the T waves. Tomorrow we will talk about the electrolyte abnormalities. From there we will go into the arrhythmias. We will run this series for another 5 to 6 sessions. We will cover arrhythmias. After that, we will cover the STEMI equivalents. And then after that, we will cover some miscellaneous conditions and ECG changes like the hypertrophic cardiomyopathy, arrhythmogenic right ventricular hypertrophy and all that. So in another 4 or 5 sessions, we should be able to cover the rest part of the ECG. So with that, I'm signing off, guys. Shankar Gowda. Okay, so Shankar, if your goal is to come back and deal with the FMG exam, I think that is more than enough. Of course, if you want to learn more, there is no replacement, no teacher, no videos or replacement to standard textbooks. So for a better, deeper learning, of course, I would suggest Harrison or Davidson. Harrison is like next to impossible to complete even when you're 2 to 3 hours in hand. So I would suggest to go with Davidson, or there's an Indian book called as API Textbook of Medicine, which are good enough. But if the goal is to crack the exam with good score, the videos and notes should be more than enough. Okay. So I'm signing off, guys. I'll see you tomorrow again at the same time. We will be talking about the ECG changes in electrolyte abnormalities, which is an important NEET PG MCQ topic.